be talking about the external ventricular drain and the lumbar drain, which you can't see right now, but it's down here. So both of these systems are necessary if there is an increase in CSF fluid or intracranial pressure that needs to be changed. So you might have two situations for that, either an overproduction of fluid, as in hydrocephalus, or a blockage in the flow, like an interventricular hemorrhage, leading to blood in the ventricular system, clogging that system, preventing the fluid to flow appropriately. So either way, we need to remove some of the CSF from the body to decrease intracranial pressure and let the patient's neurostatus normalize. So what the neurosurgeon will do will introduce or perform a burr hole into the cranium, and they'll palpate down to the level of the lateral ventricle and place or produce a ventriculostomy, and they'll introduce the catheter of the tip, which is a flexible rubber, into that site. That site exits the cranium. They produce a circular pattern, a loop pattern essentially, on the skull or on the scalp, and that is stapled along the scalp, covered with tegaderm to allow for a primary and secondary anchor. So that tubing is connected to this system here, which is a hard plastic tubing that runs from the patient's head over here to the drain system. And there are multiple clamp sites like this along the drain. The most important one that we need to know is this one here. And as you see here, this is in the down off position versus this would be open or unclamped. So prior to mobilization, what we need to do is ensure that this system is clamped. You should be able to read off, straight down, and then we're able to mobilize. So when we enter a patient's room, what we'll see is this system, which can be hooked up to a transducer from here, that will be hooked up to telemetry, and you can read on the telemetry monitor what that person's intracranial pressure is. So our limit is 20 and below. Less than 20, we're able to see these folks for mobility. So first you'll see the ICP, as long as that's in a good range. And then the next step is talking with your nursing staff to make sure that this is clamped. So prior to mobilizing the patient, this needs to be clamped. Otherwise, you're going to be changing the patient's position relative to the drain, which could negatively increase or decrease the amount of fluid draining from the system, which could lead to a change in neurostatus, which is absolutely what we want to avoid. So the nurse will clamp the drain for you, and then you're allowed to mobilize after everything is disconnected from the telemetry, as you would other equipment in other critical care areas. So as you're working with the patient, one of the biggest things that you need to be cognizant of is change in neurological status. So we're talking about headaches, slurred speech, change in cognition. Are they confused? Are they having increased paresthesias or strength on one side or the other that was different from before you started? So that could mean that because you have now clamped the system and the drain is not doing what it's supposed to, that intracranial pressure could be increasing, causing those neurostatus changes, which is going to be a good time. It's going to be a good hard stop for you to go get that patient back in the bed, back in the chair, done with therapy, communicate that to the nursing staff. They will re-zero and open up the drain and allow the drain to work and decrease intracranial pressure and allow that CSF to drain truly through the EVD. So now after you've mobilized the patient, you're getting them back in the chair. What you're going to do is hand off to the nurse and let the nurse know, okay, hey, now the drain needs to be re-zeroed and unclamped. So what the nurse is going to do to re-zero the drain is they will move this drain. So this is the zero position, red zero relative to where the transducer is going to be. They will re-zero it, move it up and down on the pole like that, and that's going to be relative to the patient's ear. So there is normally a string with a level on it that they can take from the drain apparatus to the patient's ear to ensure that it's level. There's a bubble level on that. It's a nice system. So once that it's re-zeroed, the nurse can then open the drain, and now the system is working as it did prior to you mobilizing the patient. Another thing to take note of is after you've mobilized the patient, that softer rubber tubing that goes from this tubing into the catheter that goes into the skull is a much softer tubing that can kink and twist on itself. You know, if the patient has moved and rotated too much, When you get that person stationary, that could kink on itself. You want to ensure that that tubing has not kinked or twisted prior to leaving that patient. That's something that you want to ensure so it's not affecting how the system is draining. Okay, so you've got the patient in the chair. There's no kinks in the system. The nurse has re-zeroed, has opened the drain. So everything's back to normal. The system is draining at the level that the neurosurgeon has prescribed it to. So the level of drain is referenced to this scale here, which the black is centimeters of water, the white over here is millimeters of mercury. So typically our neurosurgeons are prescribing this in centimeters of water. Lower down, closer to 0 and even into the negatives is going to be an increase pulling a fluid off, and as it's raised, that pressure gradient is getting harder and harder, so less pressure or less drainage is happening. So initially when the drain is placed, you're going to be around 0, or maybe just slightly bit higher, and as that patient is improving and the nerve status is improving, they can increase the level of the drain based on the neurosurgeon's prescription, and as it goes up, it's harder for the fluid to drain, and so the body is having to do more of its own work. As the patient is improving, each day they could raise the drain, check neurostatus, check a CT, and then they'll again, as long as everything's good, they can raise it higher to the point where, okay, it's been 2 days, we've raised the drain. Now the next step would be to clamp the drain. Just like they would clamp for mobility, they're going to clamp here and make sure that everything neuro-wise and the CTs stay clear. And that is what's called challenging the drain, as you're increasing that level of the fluid flow of the drain, making it more challenging for that fluid to flow out of the body into the drain. Okay, so another interesting tidbit that we need to know is if you go into the room working with this patient, you're waiting for that nurse to come in and clamp the drain, you're talking with the patient, they start to code, your first step is to hit the code button, your second step is to make sure that this drain is clamped. Because what you want to do is obviously you're going to lay the patient down, perform CPR, and that CPR is going to increase intra-abdominal pressure, which is going to increase intracranial pressure. So you're changing what the drain is doing, so you want to make sure that you're not causing too much distress with this patient. You want to make sure that their CSF is normal or fine. So clamp the drain so there's not additional challenges. So one last thing that I'd like to talk about is the lumbar drain and the EVD have what's called, right on the top of this top reservoir, is a vent system. It allows for air to flow through freely, which allows the fluid to drain appropriately. I refer to one of the big laundry detergent bottles that has the tap on it. If you don't unscrew that top cap, then the system drains slowly, but you unscrew the top cap, you allow that vent to happen, the fluid drains more freely. So that's what this top vent is. It's a hydrophobic vent. If it gets wet, it can affect how the system works. And so if something happens during a physical therapy, occupational therapy, speech session, we need to make sure that remains dry. If it gets wet during our session, we need to make sure that's something that we pass along to the nursing staff. Okay, so that's the basis of the EVD and what we need to know while mobilizing with therapy.